Welcome to Inside the Doctor's Studio Retina. I'm your host, Arshad Kanani. Today, we are talking about addressing the neovascular AMD treatment burden, a focus on the port delivery system. It's my real pleasure to have my good friend, Dr. Michael Singer from San Antonio, Texas here. Hi, Michael.
Hey, Arshad, thanks so much for having me. I'm excited to be on the Doctor Studio.
No, we're excited to have you, Michael. Tell us a little bit about how you got into ophthalmology and retina, and was there somebody or many people who inspired you to be a retina specialist?
So I got into ophthalmology because when I was in high school, I was really interested in holograms and lasers, and I was really fascinated by optics. So the concept of essentially how the eye works and how it focuses light and how you take a two-dimensional image and make it three-dimensional really fascinated me. And that kept going, but that was my favorite part of physics. And then obviously I went to a 6-year medical program, and then I always wanted to go into ophthalmology. And Yale Fisher was someone who really inspired me, as well as Rick Spade, to go into retina. I watched how they both were such great surgeons and how they really made a difference, and how retina had a lot of unanswered questions at the time. And I was excited to see if I could take on some of these challenges in my own small little way.
That's a great story, Michael. So you say you went to 6-year med school?
Yeah, I went to undergrad and medical school in 6 years.
Where did you go?
At Boston University.
Oh, nice. And are you from East Coast or?
Originally from East Coast, originally New York and Boston.
So what brought you to San Antonio, Texas?
So it's pretty funny. One of my wife's maids of honor was filming a movie down here, and I was head of retina for Kaiser in Southern California. And basically it was what is it? Pet Detective 2. Jim Carrey's movie. They filmed it in San Antonio. Love it. So we came down as a bit of just to see what it was like. And, we fell in love with the city, and, people really cared about us, and they kept checking on us when we got back. And we thought, this is a great place to raise a family. So we came down, and at the time there were very few large practices at all. So I joined a multi-specialty group, and the rest is history.
Amazing. And you have done so well, Michael, in terms of being involved with clinical trials, coming up with innovation, presenting the data, publishing the data. Clearly, you have done an excellent job. And I like you because you think very critically. And that's what you told me just now, that you are very interested in physics and optics, and you're always looking to do things in a unique and different way. I remember, I think it was you and your daughter presented the Ozurdex. Let's get that. I remember you and your daughter presented dexamethasone implant video at ASRS, and it won an award. So really, really nice to see that you are always thinking outside the box. So Michael, let's move on to patient management. Tell me, what do you think is going to be the biggest game changer, in your opinion, in management of neovascular AMD, let's say in the next 5 years?
I think what's really going to be a big game changer is we're not going to have an arsenal of medications. They're going to decrease the treatment burden. Right now, obviously, there are lots of surveys that talk about the fact that one of the biggest unmet needs is that patients need to come in every month or every other month. And as a result, patients have a lot of treatment fatigue, and then patients get lost to follow-up, and all the great results that are seen initially either through clinical trials or through patients' experience with having 3 loading doses very quickly start to diminish, and sometimes even get worse because of the fact that the treatment burden is just too high for patients. I think medicine's coming down the pike, like the port delivery system, like faricimab, like potentially the ABC platform from Kodiak, and gene therapy, all seem to have real promise in terms of decreasing the treatment burden and increasing the interval between patient shots. So hopefully patients will be more compliant.
No, I think that's those are excellent points, Mike, because we have good standard of care now with good efficacy and very good safety, and anything coming new, it's a very high bar. But I think the data we are seeing, especially the phase 3 data for faricimab from Tenaya Lucerne, where we saw an anatomic effect and durability that's better than aflibercept, and then obviously comparable safety. And then, of course, the port delivery system, as you mentioned, phase 3 Archway study read out last year, and we are seeing longer term data, and Carl Regillo presented the 18-month data at angiogenesis. So Michael, how do you decide, let's say you have faricimab and KSI 301, and then you have a surgical procedure like port delivery system, which has really shown significant decrease in burden for our patients, right? In ladder, patients went about 16 months median before their refill. In archway was every 6 months, but we know that in ladder, 80% or so went longer than 6 months. So we know patients may need even less than 6 months refill. So how do you decide what you're going to offer to your patients? What are the reasoning? And then if it's a port delivery system, how do you talk to your patient about it?
So I think, in a couple of years from now, when we have all these medicines at our disposal, I think it's going to be very individualized treatment. I do believe that faricimab, given its dual mechanism of action, will be very good in stabilization in some of these more difficult lesions to treat, because the Ang2 factor, I think, will actually work in. And essentially, I could see you starting a lot of people on faricimab, but I also could see patients don't like shots. I mean,
Right.
as much as you say it's not going to hurt, and actually we're involved in, you and I are involved in a new way to numb patients, it's still very traumatic. Obviously, we have to start with the concept of, stopping what your mother used to say, you're going to poke your eye out with that needle, right? I mean, everyone's got that fear. And even though you overcome the fear, and I hear patients say, even though I didn't feel it, you get very nervous. I mean, Jonathan Prenner did a great job of writing an article about that. It takes 9 hours and how much psychological trauma injections are. I do believe there are going to be a good percentage of people that once you explain the value of the port delivery system, they may go for it. Obviously, high need people are going to be more likely to want to do it because people have to come in every month to get shots. They're going to be better off with continuous delivery. And continuous delivery, I think, will make a difference in these type of people. Obviously, you have to explain it in such a way that patients understand it. It's funny right now. It's the positive phase 3 data for AMD has been talked about, but obviously Yosemite and Rhine had great data in terms of faricimab for DME. What's going to happen with Pavilion and Pagoda, if they do just as well, people get the concept of an insulin pump, right? That's how we're getting to this concept for pain management. All these implantable devices are becoming more and more mainstream. I think it's going to be easier to explain people over time because they have something they can relate it to. But it is a surgical procedure, and obviously that's going to be important to understand that there are some risks involved. And as we get more and more experience with it, obviously it's a lot of these potential complications hopefully will be minimized. And I think for the right patient, it's great. I mean, right now we have these decisions we have to make in our own clinic because you and I do many clinical trials and we have lots of options out there and different people want to go for different things. But I think really the fact that patients may only need to be seen probably very rarely and may have refills every 6 months or longer, I think will be really appealing. So the question is, do you take it in the front, early on with putting the procedure, and then it gets easier later on, or is it just slow and steady? And I think everybody has different tolerances to what they want to stomach, for lack of a better word, in terms of whether having shots or a procedure. And I think you'll be able to find the niche even better as we get more experience, not only doing the procedure, but discussing the procedure with our patients.
No, I think those are excellent points, Michael. Did you say that patients in Texas have fear? Did you say that?
Mine do. I have a friend in Houston. His patients have no fear, but my patients still have fear.
I train. I train in Texas, and I
do.
really miss.
Yeah, you train in Dallas, right? So I mean, different parts of the states have different amounts of fear. But yeah, I mean, but really, it is an interesting thing. It's everybody. But it is interesting. I don't think I'll ever start it initially because I think what happens is for the first 3 shots, people are excited to get the shots. They see an immediate benefit, right? So it's again, we're wired for negative and not for positive. So the initial positive will keep you going. People usually don't stop with me at shot 2. They stop at like shot 4 or 5, right? Because already the value of the anti-VEGF has worked well, and now they're seeing incremental improvements as opposed to huge improvements, and then they're saying, I really don't want to come for the shots running forward. So that's where I see me introducing the port delivery system when I start to get some shot fatigue. I don't see it initially. I see when people are complaining about shot fatigue, this is going to be the proposal I give you. Here's a trade. I can decrease the number of injections significantly, but we have to get a surgical procedure. That I think will be the conversation.
Yeah, and I think you and I both are in all these trials, and I've been pleasantly surprised about how receptive patients are in terms of going a procedure that's outpatient, pretty similar to cataract surgery, and they don't want to have injections. But obviously, it's a surgical procedure, so we have to talk about the efficacy and safety. And since ladder, we have learned a lot about mitigating, especially the vitreous hemorrhages with laser, but obviously the conjunctival erosion. Now we are learning more and more how crucial it is to close the tenons and conjunctiva well, so you don't get erosions. And I think the efficacy is remarkable, because it's compared to monthly ranibizumab, which is a very high bar, number one. And number two is the patient preference from Archway, that 93% or so actually preferred the port delivery system or injection. So I think it's a matter of picking the right patients. And we have been doing this, right? Individualized approach. But now, as you said, we're going to have a lot more options for patients. And we as physician work with the patients so we can have the best outcomes. What I'm interested in is long-term data. You wrote the Horizon paper, and we all know that vision goes down significantly after 2 or 3 or 4 years. And in CAT 5-year or 7-up study, we see vision worse than baseline. So I'm looking forward to the long-term data from the portal extension trial to see how these patients do. So if we can maintain their vision, I think it's going to be fantastic for our patients as well as our field to have long-term maintenance of vision. So Michael, next question for you is, how do you tell a colleague that has not done the surgery, has not had patient experience with port delivery system? You obviously did because you're part of the trial.
Right.
Because people get nervous about, safety and conjunctival erosion or rate of endophthalmitis. So how do you tell or share your experience with your colleagues with no experience about the port delivery system?
It's funny you asked that because that literally came up today. One of the colleagues, I presented data on the port delivery system, and he asked me, what do you think about the adoption? How is it going to roll out? I mean, the surgery is not more complicated than what we do on a regular basis. It just stresses other things, and you really hit the high points. The key thing in this surgery is that we have to do a really good job of making sure we don't cut too big. We make sure it's really like Goldilocks. We cut it just right. And then obviously conj closure, which is something retina surgeons really could care less about, right? You throw a buckle on, you whip it closed, and we do scapular surgery, so we rarely think about it. That's what really gives me the biggest angst when I do the surgery. It's not putting it in, it's closing the conj. But I do think that it's very learnable, and the company's done a great job with the SDLs, the surgical device liaisons, to kind of hold your hand all the way through it. And I think the philosophy that they treat it like pilot training, that you can't go too long without doing something, without refreshers, I really think are formulas for success. And I think in the rollout, that'll be critical. And my understanding is probably they're not going to roll it out to everybody initially anyway, because they're going to start with the people who are in the clinical trials, and then I think they'll expand it. So I think it'll be based on how interested is the doctor about adding this skill to their repertoire. Some people will embrace it, and some people won't. But I think it has value. And I think it should be something that we should think about for our patients, because it does have great potential in terms of that decreasing that treatment burden that I talked about before. And just like you said, I think from a long-term standpoint, it may be safer. I have a personal theory about geographic atrophy, and I think geographic atrophy is due to inflammation. And personally, every time I think we give a shot, we cause an inflammatory response in the eye. And if essentially we give a steady state, there may be less inflammation, because what are all the dry AMD trials focusing on? The complement cascade. What is the complement cascade? It's related to inflammation. So I have great hope to think that it may actually preserve a lot more vision, and it will take away the question that we always see on, be it the Horizon, the View extension, or the CAT study about the concept of loss to follow-up. Because I think you'll have much less loss to follow-up because the medicine will still be working. So you can't say that's the reason the vision went down.
I think that's very interesting. Your analysis of geographic atrophy and inflammation associated. And you're all usually right, Michael. So I hope that pans out very well. And I agree with you. It's a very easy surgery. You just gotta follow the steps. And a big shout out to the SDLs, right? They've done a great job, and with virtual trainings and simulation that they have set up. So I think we continue to refine this procedure. I think once it becomes if it gets approved and it's available, then I think smart guys like you will come up with innovative ways and better to optimize this procedure, because obviously right now we have to exactly do what the trial has to follow the IFU, which is instructions for use. But new blades and new tools and things like that will be meaningful. But I agree with you. I think for physicians that have not seen a patient with it or has not done the procedure, I think it's a missed opportunity to really help your patients, really have a sustained delivery platform. And remember, Michael, like for COVID, because of the pandemic, all these patients who didn't come for 6 months, they bled and lost vision. But
Right.
if I had a PDS patient who was in a trial and missed 2 or 3 or 4 appointments, they're doing fine because there is some level of activity, from the PDS releasing ranibizumab based on the PK data that we have seen that goes on for a while. So I think really good way to address the disease. But of course, as you talk about the adverse events and how we mitigate and decrease the conjunctival rate. And I didn't know that they put sutures in Texas. So that's good to hear that you're actually suturing the conjunctiva, Michael.
Only when they tell me I have to. So, yeah,
Oh man. Okay, so tell me, once let's say it's available, how do you monitor these patients? Like homo CT, do you see them frequently? What do you do to these patients? Because once they are healed from surgery, they're back to baseline. They need a refill every 6 months or less. So how do you plan to monitor these patients?
I mean, I think initially I'll be monitoring very closely just to understand what's involved. But over time, I definitely think, obviously, with the implementation of Homo CT, this is custom made for that, right? The Homo CT will tell me what's going on. That'll be the cue to bring them back. Obviously, I'll bring them back during the post-operative period to make sure everything heals up.
Right.
But I do think over time, I mean, the first refill I'll probably monitor much more closely every month or 2 months. After if I realize I'm giving a 6-month refill and they're still really dry, I'll probably just extend them out. And unless they have a problem, I'll probably look at 4 to 6 months between exams if I know this thing is working. But again, every patient is different, but I do believe that there are probably internal consistencies within a given patient. So if they respond a certain way in the first 6 months, I probably can extrapolate out from that.
I think those are great points, Michael, to manage these patients. And I think everybody will come up with their own algorithm, to manage, and we'll figure out. And, sustained delivery is really exciting, right? We have PDS hopefully approved soon. And then 5-10 years down the road, we may have gene therapy. So I think this telehealth remote monitoring will be more and more utilized, even if it's a 6-month or 12-month injection that you can do. I want to know how the patient is doing. And I think remote monitoring will be great. The other thing is to remote monitor the conjunctiva to make sure that there's no breaks and erosions, so that if you have them, you catch them and treat them so they don't end up with endophthalmitis or a significant event, so we can make sure that these patients are taken care of. Now, coming back to you, Michael, in your clinic, you're a busy guy. You're seeing tons of patients. You're seeing clinic, you're doing trials, you're answering my text messages, you're making phone calls, you're writing papers. So what is the best thing you can hear a patient say in your clinic, and what is your least favorite thing to hear from them?
Best thing I hear patients say is they tell me about something they couldn't do before, that basically restore something they couldn't. I wasn't able to drive when this thing, and now I'm able to drive again. That's something that means a lot to me, obviously, or something that increases their quality of life. That really shows me that there's some gratitude there, that they know they're making a difference running forward. Obviously, the least favorite thing to sing is that when people get depressed, despite having, we work as hard as we can, that they still lose vision over time. That's slightly frustrating when I don't have an answer to say, what can I do? Is there anything you can do? And it's a lot of these, it's sometimes usually in my inherited retinal disease patients that I'm really fumbling, because we really don't have any good therapies for that. But obviously for both dry and wet macular degeneration, because you and I do a lot of trials, at least I can offer them some hope. So when I have no hope, that's frustrating.
No, I think you bring up a really good point that sometimes you make such a big difference. Like imagine a diabetic with a hemorrhage in only their one eye, the other eye is gone, and you remove it, and now they can see their kids or grandkids or drive. That's a really, really good feeling. I agree. But then the frustration is there, right? So I tell my patient what you tell them that, hey, I'm gonna give it my best, but I know that things don't work 100% of the time. And for some diseases, we don't have any treatment, right? And you mentioned geographic atrophy and dry AMD. I mean, this is very, very depressing too, because we don't have treatments. Hopefully in the next year or two, we'll have something to help these patients. But yeah, it's a pretty bad feeling when you can't help your patients. And, you lived through the days before anti-VEGF came out. I mean, it's just, would have been really, I would have not gone into retina. They came out while I was in training, and I saw the impact on the patients, and it was like, wow, I need to go do retina because this is really revolutionary. So Mike, next question for you. What profession other than ophthalmologist would you have liked to attempt, and what profession you would be horrible at?
So actually, I would have liked to have been a food scientist. I really, a lot of people know I used to run an ice cream company for diabetics, and I still tinker. And during this COVID pandemic, they've stuck me at home. So I've been tinkering again, making interesting coffee and shake drinks that are both good tasting and good for you. So it's kind of bringing out that buried, what's called evil scientist or whatever you want to talk about,
Amazing.
to go forward. And I would have being an artist or anything to do with drawing, I'm horrible at. I failed out of art school at age 8. It's not something I do well. I'm not known for being having great penmanship or art making skills. So anything in the art world, like a graphic designer, I would have been a disaster at.
Very, very good. We're pretty similar. I love to cook, so I would see myself as a chef, and then I'm horrible at art. Like my 2-year-old can probably draw better than me. So we're pretty similar here. Yeah, next time I come to San Antonio, we need to try some of your new ice cream.
Absolutely.
Maybe for ASRS this year.
Absolutely. If nothing else, I can make a mean ice cream cocktail, if nothing else.
Love it, man. So we're running out of time. So last 2 questions that I ask everybody. What is your favorite retina related word, Michael?
Transformation. And the reason it's my favorite retina related word is it used to mean 2 different things. So it could mean, when we started, just like you said, in the old days before anti-VEGF, we had transformation. Dry macular degeneration transformed to wet macular degeneration, and there wasn't anything I can do. Now, given the fact that we have such an arsenal, we now have transformation in our therapeutic armamentarium, where now there are all these options at our fingertips that people who typically would have gone blind may not go blind anymore because of therapies we're able to deliver to them.
That is great. Transformation for Michael Singer. I love it. And last question, you already have had a successful career, Michael. You've done great, whether it comes to teaching students at the university, giving lectures, mentoring them, taking care of patients, being part of trials, being on the podium all the time, publishing a huge amount, participating in CME activities. So you have had a successful career, and it's going to go on for a while, for decades more. So what do you hope that patients and colleagues say about you when you retire?
That he made a difference. That hopefully that stuff that I've done made a difference, either on a small scale or hopefully, if I'm lucky, potentially on a large scale. It takes a team of people in both my office and all my colleagues who help create drugs. I tell my patients, you see this drug? This drug is because of somebody like you who sat in that chair before you, and my 100 friends who are around the country, and they're all my friends, who basically believed in this therapy, and now you have options. So that, like I said, that people say he was part of making a difference, and now, restoring sight to people. That's the best thing I could hear.
Amazing, Michael. It's all about making a difference for our patients, isn't it? And so we are running out of time. So nice to have you. It was an honor, Dr. Michael Singer from San Antonio, to be our guest today. I want to thank the audience for tuning in to Inside the Doctor Studio. Thanks again, Michael, for joining us today.
Arshad, thank you so much for having me. This was a whole lot of fun.
Thank you. Hi, and welcome to Inside the Doctor Studio Retina. I'm your host, Arshad Kanani. Today, we are talking about addressing the neovascular AMD treatment burden, a focus on the port delivery system. It is my pleasure to have Dr. Nancy Holkamp from St. Louis here today. Hi, Nancy.
Hi, Arshad.
Such a pleasure having you here. And before we get to talk about neovascular AMD and port delivery system and other innovations in retina, tell us a little bit about yourself, Nancy. What got you interested into ophthalmology and retina, and were there people who inspired you to become a practicing vitreoretinal surgeon?
Well, Arshad, it's a pleasure to be here. And I have been a retina specialist for 26 years. My 26th anniversary was April 1st. They actually cut my fellowship short and hired me early because they needed the help. And
no, you were so good. So they said you don't need to train anymore, huh?
I think they were overwhelmed, but it was great. I jumped right in. And I have to tell you, in medical school, my mentors were at the Wilmer Eye Institute. And in particular, Stuart Fine made being a retina specialist look like a lot of fun. And I have to tell you, the first time I ever put an indirect ophthalmoscope on my head and I used a 20 diopter lens to see the retina visibly right in front of the patient, I said, wow. And the patient's like, oh no, what's wrong? I said, no, I actually saw the retina. and I said to myself then, I said, I could spend a lifetime looking at this. It was so beautiful. And so, the rest is history.
Yeah, well, you must be really good, because when I try to use indirect, I saw my finger. I didn't see the retina for a while. It's not easy to do that, right? I mean, you give it, now you feel like it's so easy to use, but that skill is not easy and you learn over time. So you must be really, really good. And I tell you, so Nancy, where did you train? Tell us to our audience, and why did you move to St. Louis? Or I think you stayed there, right?
Well, I did medical school at Johns Hopkins, and out of a class of maybe 120 students, 13 of us went into ophthalmology, which is really a tribute to the mentors at the Wilmer Eye Institute, and just the wonderful people that they have there that make this profession look amazing. So when I graduated from medical school, there was a lot of pressure to go to St. Louis because I had two sisters living there at the time. And so I did my residency at WashU, and then my fellowship with a group that called Retina Consultants that was the retina faculty for WashU. And then they later joined together. And that group hired me, and I've been in St. Louis ever since. And for the first 15 years, I was down at WashU as part of the private part-time faculty. And then 10 years ago, I moved out to the Pepos Vision Institute and really got involved in clinical trials big time out at the Pepos Vision Institute. And it's been great.
No, I mean, phenomenal, because you are involved with so many different things, and you're doing so well in terms of bringing new treatments for our patients with retinal diseases. But what an interesting story. It's all about how our mentors inspire us, right? And once you see somebody like Dr. Fine practicing retina, I mean, I would easily guess that I would have gone into retina too, because he's such a legend. So now let's talk a little bit about clinical trials and management of patients with neovascular AMD. And I know you are really involved with the port delivery system, all the PDS trials from the early days, and you have presented the data many times. So tell us about what do you think, since you're involved in so many different trials, what do you think is going to be a biggest game changer in management of your patients with neovascular AMD, let's say in the next 5 years?
Well, Arshad, in the next 5 years, it really will be the PDS and faricimab and some of the designer drugs like KSI 301, the treatment modalities that give us extended durability and can decrease that treatment burden. So I'm really excited about implementing these things into my practice. And in fact, I'm just going to say that there's nothing I do in my practice today that's the same as when I trained 26 years ago. And so I'm always looking for what's next. I'm always looking for the new data. I'm always looking to improve what we bring to our patients every day. And so I'm really excited about the next 5 years in neovascular AMD. But if you want to look even farther, maybe 5 to 10 years, I'm very excited about gene therapy for wet macular degeneration. And our shot, if we can just pivot a little, I think the landscape's going to get very exciting for dry macular degeneration. I am so excited about new data that's going to come out this summer, and even in 2022 and 2023 about potential treatments for dry macular degeneration. That's going to be a huge game changer for us. I think, if I had to see the future, I think I would see that our treatment duration is so extended for wet AMD that we will find our clinics being really busy giving injections for dry AMD until we can then take the same technology and extend the treatments for our GA patients. So, the next 10 years are going to be great.
No, I think very exciting times. And I think you bring a good point about GA, right? I mean, we used to feel similar frustration and depression seeing these patients go blind with wet AMD before anti-VEGFs came out. And I agree with you. I think any treatment for dry AMD at this point to slow the progressive vision loss would be great. And so, Nancy, you mentioned injectables like faricimab. We showed really positive data in the phase 3 Tenaya and Lucerne trial in terms of durability. And then you're talking about KSI 301, which is antibody biopolymer conjugate with pivotal trials that are ongoing. And then the port delivery system, which showed excellent efficacy and non-inferiority to monthly injections of ranibizumab in the Archway study. So tell me, how do you identify patients for each of those? Let's say you have injectables available, you have something that's more sustained, but it's a surgical procedure. So what kind of patients you think you're going to be choosing for something like port delivery system?
Well, I'm actually going to talk to the patient about it. Some of the most impressive data to me from the Archway clinical trial was the fact that 93% of patients preferred the PDS over injections. And prior to getting into Archway, on average, patients had had 5 injections. So they know what injections are like, and they also know what having the PDS is like. And 93% had a preference for the PDS. So I think if we as physicians remain focused on what the patient wants or listen to what patients want, I think we're going to have a bunch of people getting injections now that want to transition over to the PDS. And so I'm going to encourage all doctors, all retina specialists, to talk to their patients and find out what they want. Now, the patients that don't have the PDS already don't know how great it is. So it's going to be important to be fair and balanced about the safety profile. It's going to be important to give them something relatable about what it's like to have surgery for the PDS. And I think we're fortunate because most of these AMD patients have had cataract surgery. And so I tell them that the PDS is just like your lens implant, except this time it's a drug implant and it requires a 30-minute procedure to place in your eye. And once it's there and you're healed, you really don't even know it's there anymore. It's kind of like having a lens implant. And so I think we'll have a language. I think we'll have a reference point for talking about the PDS with patients for whom this will be new information. But looking forward to having those conversations. And for patients who are not surgical candidates, very excited to have drugs that seem to extend the treatment interval. And there's really good data, as you said, in Tenaya and Lucerne. The anatomical data was very good. And if the anatomy looks good, we physicians feel we can extend. And the PTI arm in those clinical trials looks very good. So certainly looking forward to the approval of faricimab and using that. And then KSI 301, really excited about that technology that really looks good in early phase clinical trials, waiting for the phase 3 clinical trial data.
No, I think, Nancy, I agree with you. Those are excellent comments. I think the patient preference actually does translate into, what I've seen in my experience with Ladder and Archway and other port delivery system trial is that these patients are coming in smiling and not nervous compared to their personalities change. And I always wondered, like, is it just me that I feel like, am I biased that these patients that I have done the surgery for, they're happy, or is this a phenomenon that's being seen across the board? And as you said, 93% of patients preferring port delivery system is a really positive signs that patients are actually welcoming port delivery system, because it's very hard to just keep getting injections month in, month out for the rest of your life. So I agree with you. I think once we start talking to the patients, and that's why we recruited so many patients in the Archway trial, because pretty much everybody who qualified said yes, because they don't want injections. And so I think that's the point you're trying to make, is that I think as long as physicians feel comfortable doing the surgery and managing the adverse events, or aware of the safety. I mean, we know that surgical procedures are never going to be as safe as doing injections, but I think the additive effect of continuing injection and the risk of vision loss that you have expertly published about in the real world, I think those are the things we will consider. So tell me, what do you say to colleagues who have not done the surgery, who have not seen these patients, and they're nervous about conjunctival erosions? How do you tell them that this technology actually is real and they should consider it because it's good for the patients in terms of controlling their disease?
Well, I think that I'm going to use the analogy of cataract surgery again. I don't, you're not old enough to remember cataract surgery in the old days, but it wasn't very elegant. At least it isn't what it is today. And cataract surgery kept getting better. And we have a lot of smart people in our field who make incremental changes. And then we build upon those incremental changes. And already, the instructions for use for the surgical manual for putting in the PDS has changed and improved, from lowering the incidence of that vitreous hemorrhage to hopefully lowering the incidence of conjunctival erosions and retractions. So I think it's going to get better and better as we do more of it, and as we get more smart people involved in developing the techniques for improving a pretty straightforward surgical procedure that still requires a lot of detail. And Arshad, I want to just circle back. We're very good at measuring vision. We're very good at measuring OCT thickness. We're not very good at measuring or quantifying patient anxiety or patient fear. We're also not really good at wrapping our heads around the vision loss that occurs because of undertreatment.
Right.
And so those are things that we have to find some way of reckoning with when we choose a treatment for our patients. And the PDS is really a good way to deal with the undertreatment and vision loss, and a good way to deal with recurrent patient anxiety and fear about injections.
No, I think those are excellent points, Nancy. And I think that's why I want to see that long-term data in the portal trial, 4, 5, or even longer years after getting the PDS. Can we maintain vision? I think that's going to be really powerful, right? Because based on your work and all the other work our colleagues have done in 7-Up and CAT trial, and we know that long-term, the visual acuity is actually below the baseline in most of these patients. So can we keep and maintain that visual acuity? I think you bring a really good point about the fact that we need to make sure that we understand that there is vision loss in our patients down the road. And I think we don't realize, because we think this is somebody else's patient. Oh, my patients all come. That's what I thought until I started looking into how many patients were lost to follow-up, or how many patients disappeared for 6 months and came back with a bleed and lost vision. So I think those are the points, is that once you put port delivery system, I think you are confident that as long as they come minimum 6 months, and as we know in Ladder, median time to refill at the end of the trial was almost 16 months. So as long as they come in minimum 6 months, some of them may need to come in 9 or 12 months once they're stable. Of course, after they're healed from the surgery. There are no issues. So I think decreasing that burden will be huge. So how do you anticipate, Nancy, your patients responding to a surgical procedure, number one? And then how do you monitor these patients? Let's say if you put something like a port delivery system.
Sure. So I had an interesting conversation with a PDS patient just this week. I said, "Oh, how's it going?" Because she knew she wasn't going to get a shot. So we kind of just chat. And she said, I love the PDS, but looking back, I have to tell you, I was a little concerned because I had blurred vision for about a month after the surgery. And I said, well, you're absolutely right. We see that when we look at the data. And I said, I'm going to do a better job of preparing patients for about a month of blurry vision, that expected post surgical drop in vision. So that was a pointer that I learned from that patient. But as far as monitoring patients, I think 98% of patients went 6 months without needing a supplemental treatment. I'm not sure that I really need to follow these patients very closely. And if I want to extend further, I'm really looking forward to home monitoring with a home OCT. And I'm currently involved in an early phase clinical trial in the United States with the home OCT, which I'm very, very excited about. But I think telemedicine is part of the future. And I think being able to monitor patients from home and using artificial intelligence so that we don't have to scroll through every single daily scan is really going to be cool. And I'm very excited about that aspect of the future of our profession.
No, I agree with you. I think I'm impressed with how great those OCT pictures look and how easy it is to access them on a daily basis to see how the patient is doing. So yeah, clearly home OCT is going to be a fantastic addition, and hopefully we have availability in the near future. And then, for something like PDS, having some sort of a device monitoring technology, whether it's a camera, whether there's a video or something where we can actually be reassured that patient is actually not having any conjunctival erosions. And you know that erosions can be repaired easily, but what you don't want is endophthalmitis and further complications. So I think better patient education and remote monitoring of that would be great too. So talking about patients, and Nancy, what is the best thing you can hear your AMD patients say, and what is your least favorite things to hear from a patient?
So I love it when my patient says, "Okay, doc, let's get a shot." Because we just reviewed their OCT. They are totally on board with the fact that we're lucky to have these injections, and they know that the injections are maintaining, protecting, preserving their vision. So if I have a patient who says, "Okay, let's get a shot," then I know they're on board with me. My least favorite thing is a patient who says, "I don't want a shot," or "Why do I have to keep having these shots?" Because then I know they don't fully comprehend the goals of treatment or what we're accomplishing with this treatment. And it means I have to work a little bit harder to get them fully on board. So those are my favorite and least favorite things.
That's very interesting. So where are most of your patients? Are they in the first category or they're in the second category? Because most of my patients are in the second category.
Yeah, well, it's kind of a yin yang. Maybe after a good experience, they don't mind it so much. After a bad experience, they switch groups. But I tell you, the way that I keep patients committed to the treatment plan is by developing relationships. I've got a great staff. We have no turnover. Everybody's cross-trained. Everybody smiles. We really run an efficient clinic so that patients are there for maybe an hour and a half tops. And we have a big office, a lot of space. It's easy to socially distance. It's bright colors, good art on the wall. People actually like coming to see us. And I think that helps maybe ease the pain of having an injection.
Yeah, you're very kind. You kind of said that the office and the staff makes a difference, but we know it's you, Nancy, and you're so good at communicating, and you're so nice to your patients, and I'm sure that's why they're coming in. And of course, having a nice office and staff obviously helps, but I think at the end of the day, if they like the doctor, they're gonna come, and I'm sure they all adore you like all of us do. So tell me, the next question is, what profession other than being an ophthalmologist would you have liked to attempt, and what profession would you have been horrible at if you were not a retina specialist?
So I'm sure you're going to hear this over and over again. I would like to have been a professional golfer.
Oh,
And
yes,
what
of
what
course.
held me back was talent.
But you're a pretty good golfer now, so I'm sure.
No, you really got to be special if you're going to be a professional golfer. And it takes the same amount of time and the same amount of practice. But as you and I know, Arshad, medical school didn't take a lot of talent. It just took perseverance, right? But I think being a professional golfer would have been awesome. That would have been my ideal life plan. But I was lacking one critical aspect, and that's talent. And then the profession that I would have been horrible at,
Yeah.
dancing, professional dancer. I got no rhythm.
That's very interesting. Those are very unique answers, Nancy, but I know you love golf. So I think if you keep trying, you will get good at it. I'm sure you are better than all the other retina specialists. So that's actually a good thing. And tell me, last few questions before we end this episode that we are having so much fun with. Do you have a favorite retina related word that you can tell us? I asked this to all our guests.
So over the last 15 years, I've become very fond of the MAB lexicon, as in bevacizumab, ranibizumab, and brolucizumab. So they just kind of roll off your tongue right now. I really enjoy saying them. You know, at first they were odd words and very awkward, and now I kind of like the MAB lexicon. I think it's fun to say.
Very, very interesting. But you know that not all of our colleagues can pronounce those words properly. So that's very
It
good.
takes practice. I've been practicing for about 15 years.
No, very good. And then the last question, Nancy, you said you've been doing this for 26 years. You have really been a pioneer in so many things. You have contributed so much to our space. You have really pushed our field forward, and we are so thankful for that. So when you retire following this successful career, I know you got another 20, 30, 40 years in you. What do you hope that patients and colleagues say about you once you retire?
Well, I hope they say slightly different things. Both positive, I hope, but slightly different. I hope patients say, gee, I really miss Dr. Holkamp. That's all I want. I hope they say I really miss Dr. Holkamp. And for my colleagues, I hope that they say, gee, Dr. Holkamp was a real asset to our profession.
Very well said, Nancy. Thank you so much. It was really good having you on Inside the Doctor Studio. Retina, I also want to thank the audience for listening to this episode. Thank you again, Nancy Holkamp from St. Louis, Missouri. Have a good
Arshad,
day.
it's always a pleasure, Arshad. Thanks so much. It was fun.
Thank you, Nancy.
Bye.
Hi, welcome to Inside the Doctor Studio Retina. I'm your host, Arshad Kanani. Today, we'll be talking about addressing the neovascular AMD treatment burden, a focus on the port delivery system. It's my pleasure to have Dr. Carl Ruggello from Wills Eye Hospital here with me. Welcome, Carl.
Thank you, Arshad. Great to be here. Thanks for having me.
We're honored to have you here, Carl, today. Before we get started, tell us a little bit about yourself, how you got into ophthalmology and especially retina, and were there any mentors or people that really guided you in choosing this specialty?
Oh, sure. Well, that's a long, complicated story, really, because for me, it's one thing led to another. I didn't grow up in a medical family. The science brought me in the direction of medicine, if you will. I actually started as an undergrad in pharmaceutical sciences, and I really enjoyed that, really enjoyed pharmacology, and was even thinking of a PhD. But working in a hospital as an undergrad really got me in the direction of medicine. I loved surgery. I loved the clinical care in addition to the science. So that got me from pharmaceutical sciences as an undergrad to medical school. In medical school, I looked a lot of different specialties. I thought I would have been maybe a cardiologist or something on the medical side. But again, I really was intrigued by surgery. And then microsurgery came along with a core rotation in ophthalmology at Mass Eye and Ear. That changed everything. It was an immediate love affair, if you will, with microsurgery and ophthalmic care in general. Not even retina at this point. Retina was not even part of the picture. But there are a lot of great folks there that influenced my career choice to go into ophthalmology. And then at Wills Eye, that was further fostered, and ultimately rotating through and getting some real retina experience brought me into retina, and then retina fellowship and career and so forth. And at Wills Eye, there were lots of wonderful mentors, folks that I ended up joining in practice ultimately. Bill Tasman, probably at the top of the list. And, when I think of mentors, I think of folks that, senior folks that trained me, that I looked up to and admired and fostered my development. But there are also mentors from afar at different institutions that I interacted with or got to know over the years. Harry Flynn comes to mind, Don D'Amico, and so forth. And also peer mentors. A lot of people around me training, maybe just a year or two ahead of me, or even in my own class, influenced the paths I took. So mentorship, it comes in all sorts of flavors, if you will.
Well, that's a great story, Carl. So you didn't want to go into medicine, and then you got interested, and then one thing led to another. That's excellent. And you trained at Wills Eye for your fellowship, and you decided to stay there. Why was that? You really enjoyed teaching, as well as the big name. I mean, in terms of so many famous people are at Wills Eye, and I think the group there is one of the best groups in the world. So tell us why you decided to stay there after training.
Well, Wills Eye is a wonderful environment to train and to practice. And in particular, to practice, you have a lot of latitude. You can do as much or little as in academic medicine as you want, and you have all the opportunities, especially for clinical research. And ultimately, I did a lot of that and do a lot of that now. Actually didn't stay at Wills. I had a military scholarship commitment from medical school. And so I practiced retina for 4 years in the military, went out to San Diego, where I was stationed at the Naval Medical Center, and practiced retina there. But I ultimately, when it came to the end of my commitment, looking around, I actually looked on both coasts and all around for different opportunities. I'm from Boston. I thought about going back to Boston, looked at opportunities there. Thinking about staying on the West Coast. And so I looked at a lot of different things, but I ultimately was drawn back to Wills for those very reasons. Some wonderful people that I trained with that ultimately I then joined in practice. It is a private practice, so you get sort of, as I say, the best of all worlds. Private practice, busy clinical environment where you really get to be a top-notch clinician and surgeon, and also the teaching and for me, the clinical research, in particular, the clinical trials work that I've been doing through the years.
Well, that's interesting. I didn't know that you went to San Diego. You may be the first person that actually moved out of San Diego after living there for 4 years and going back to Philly, but I understand you're from East Coast. So let's get back to talking about neovascular AMD and patients, Carl. What do you think is going to be the biggest game changer in management of your patients with neovascular AMD in the next, let's say, 5 years?
Well, the next 5 years is going to bring about, I think, substantial change for the better. A lot's going to evolve. At the very least, we're going to have some more durable injectable anti-VEGFs for us to use in the office. So I think we're headed into the second generation of anti-VEGFs, more durable, better drying, all those potential advantages. And that's within the next couple of years. We also have the port delivery system, which I think is in the game-changing category for sure, because it's the first true sustained delivery of anti-VEGF, and it could tremendously reduce the burden of injections for our patients. So that's also within the next few years. And then probably the biggest game changer, potentially a little further out down the line of 3, 4, 5 years from now, would probably be gene therapy for the treatment of wet AMD with anti-VEGF.
No, I think it clearly is very exciting times for patients. And also as us, you and I work on so many clinical trials, and it's so nice to see patients doing well with different approaches. And as you mentioned, faricimab showed really positive data. It was released a couple months ago, excellent durability, 80% or so going Q12 weeks or longer. And then port delivery system that you have been closely involved with and presented, and the Archway data. And so I think it is really exciting times. So when you think about different approaches to managing your patients with neovascular AMD, you have longer acting injectables versus a surgical system like port delivery system. How do you identify or patients that are going to be the ones you're going to put in, let's say, put in a port delivery system versus keep treating them with injectables in clinic? Is there any thought process you're going through in terms of identifying those patients?
Sure, absolutely. I think, as some put it, you sort of go for the low-hanging fruit, the types of patients that are probably going to be most motivated to want to change what they're doing for something that's more durable, whether that be an injectable or device, and which in this case with the port delivery means a trip to the OR. And those types of patients are the patients we're treating, and many of them are doing very well, but requiring very frequent treatment. So we're talking about the frequent flyer patients, those getting anti-VEGF injections every 4, 5, 6 weeks. And in fact, we're conducting the survey. We had a pilot survey, and we're expanding it to a larger scale survey of patients with wet AMD getting injections and their retina specialists, and asking them, looking precisely at the risks and benefits of both ongoing injections and the port delivery. And as you would imagine, preliminary results are showing the patients that are most inclined and the doctors that are most inclined to want to offer it and do port delivery for patients are those patients that are getting injections frequently. So in the maintenance phase of therapy, doing well for the most part, but just requiring frequent treatment. And those are the patients. That's the first group. That's not the only group potentially, because as time goes on, as we get more familiar and comfortable with the surgery and with the device in general, and as time goes on, we expect other advances to help us monitor these patients. It could very well be patients getting drug even less frequently than that might opt for something like the port delivery.
Yeah, and you and I are both involved with these trials. So I think you made a really good point that patients who are getting frequent injections, they're super interested. When I offered this, the trials to the patients, when the trials were recruiting, majority of the patients were okay going through a surgical procedure, as long as, they thought that I'm comfortable doing the procedure. And number two, they can decrease the number of injections. And as you know, in the latter trial, the median time to refill was almost 16 months. And the phase 3 that you have presented many times is fixed 6 months refill. But I think once we start using it in the real world, patient can go much longer than 6 months before they get a refill. So I think really addressing the treatment burden with this technology. But how do you present that to the patient? Do your patients respond positively to have a surgical option that can treat their disease, or do you get a lot of resistance? Because my patients have been really positive, and of course you presented the patient preference from the trial, which is very positive with the port delivery system.
No, you're absolutely right. My experience is similar to yours. As an investigator in both the phase 2 ladder study and the phase 3 Archway program, in addition to others now also currently underway, I was surprised. Patients who were very motivated, very interested, very amenable to the notion of going to the OR. And it was probably one of the easiest recruiting studies I've done. And these are patients getting injections. And we all know most patients tolerate these injections very well. But the fact is, they don't like them. And they get very anxious and so forth. And they'll put up with it, of course, because it's saving their vision. They can see the benefit. But if you say, look, I've got something that you don't have to get an injection nearly as frequently, maybe once every 6, 9, 12 months or more, as you indicated, they're all for it, even if it does mean coming to the office relatively frequently. So they would rather come to the office frequently and not get an injection than have to get ongoing injections. I think we underestimate the anxiety and dislike for injections that our patients have, albeit as we said, we know they're safe and generally, again, well tolerated.
No, I agree with you. I think the patients I put in these trials are the ones that actually never came to my office smiling. And then now they know they're not getting the injections, and they have different personalities and much more lively. So I think there is clearly that anxiety of injections and patients have been happy in the trial, as we saw from the patient preference survey, which was above 90% preference for a port delivery system. So Carl, you and I have done these procedure quite a bit, and we feel comfortable with doing the surgery and managing these patients. But quickly, how do you tell your colleagues at Wills Eye or other places that have not done this procedure, is this procedure hard? Is refill challenging? And of course, the adverse event profile of a surgical device will never going to be as good as intravitreal injections in office. So how do we balance the safety and efficacy?
Well, when it comes to what I tell my colleagues about the surgery is not difficult. It's unique. There's some unique steps, but it's easy to learn, to master, and it's very straightforward. There's just attention to certain aspects of the procedure that are very important with regards to minimizing both intra and postoperative complications. The good news is, you're right, a device and a surgery will probably never look to be as safe as intravitreal injections. But keep in mind, a course of intravitreal injections, many injections over many years, you're dealing with a cumulative risk profile for that patient. And when we're talking about the device and the adverse events during the course of a trial, it's a per patient over time profile. The good news is, the latest data, which I presented at the angiogenesis meeting in February 2021, is that now we're about 18 months of follow-up in the Archway, and it seems like most of the adverse events are coming early on in the study, either perioperative or within the first 40 weeks. We're seeing less and less new problems or recurrent problems beyond that. So we're better understanding these types of complications, how to best look for them, monitor them, address them, and prevent them.
No, I think those are great points. And by the way, excellent presentation, Carl, at Angiogenesis. I learned a lot from that presentation, especially, the long-term data looking pretty positive and very consistent with the primary analysis, which is great news. So the next question for you just mentioned it. How do you anticipate following your patients with port delivery system? Are you going to see them, let's say after they heal in a month? Are you going to see them quarterly? Are you going to see them every 6 months? Are you going to have general ophthalmologists or optometrists do OCT? What do you plan to do in managing these patients? Because in trials, they're all coming in every month or every other month in the portal trial. But of course, in the real world, it will be less.
No, you're absolutely right. It will be less for sure. And even in our extension studies, we're seeing them less. But that's after a given time frame. So what I anticipate is a sort of 3 stages. The first stage is the perioperative stage. So that's going to be pretty basic. You're going to see the patient a day, a week, and a month after the procedure, and pretty much then thereon it's healed up, and you're ready just to monitor. And you're monitoring 1 or 2 things, right? You're monitoring disease control, when they might need the device to be refilled. And you're also monitoring for problems related to the device. You want to check it out, make sure there's no erosions or retraction of the conjunctiva that might set up for infection and so forth. So I'm going to follow them a little closer at first, maybe every couple months. And most of that's going to be really in order to determine when they might need a refill. And so it's going to be office visits. It's going to be office visits by me. I don't want to delegate this to anyone else at this time. I want to be looking specifically and getting comfortable with the device in these patients. What I anticipate is after about a year, spreading the follow-up out more and more, again, depending on how they're doing, disease control, what the device looks like, and so forth. And what's going to also come into play within the next couple of years is the potential for remote monitoring. It's a given. We're going to have home or remote OCT types of monitoring programs and devices available to us. And that's going to be ideally suited for this, to know exactly when a patient needs a refill. So I think we're going back to PRN style of therapy, put the device in, it's filled initially, and then determine when they need their first refill. And I'm not going to refill it on a fixed basis. I highly doubt that, even though that's what we did at phase 3. Of course, like every other phase 3 trial, we never really follow the treatment pattern from the study itself. But as you said, based on ladder, many of these patients can go a year or more potentially before they need a refill. So absolutely, I'd like the patients to go as long as possible. And we might even have remote ways to monitor the device itself. That's being explored. So that's also going to be very interesting, because with both at hand, remote device monitoring, remote disease monitoring, we might be able to see our patients relatively infrequently with this device.
No, I think those are excellent points, Carl. And I agree. I think just like we're shifting the paradigm on treating these patients with sustained delivery, like port delivery system, we're also going to have to push the envelope on home monitoring of the device, as you said, whether it's a iPhone or any phone with a camera that patient can use to take a magnified picture that can be sent to you and I, and we can look at it and say conjunctival looks good, let's do it again in 3 months or something like that. So yeah, I think that's going to happen, because I think telemedicine, especially with COVID pandemic, we have learned that we need to look at options where patients don't need to come into clinic. And I think PDS fits really well for treatment, and of course, monitoring these patients remotely would be great. So now let's get back to your clinic. So what is the best thing you can hear your patients say in clinic, and what is your least favorite thing for them to say to you?
Oh, well, I love it when I hear patients say how grateful they are that these drugs are around, and that it's saving their vision to allow them to continue to function well. And that's by far, I lived the era before anti-VEGF and saw, the average wet AMD patient turn into a disciform scar with permanently poor vision. And it was a terrible time. We could do very little for our patients, and they don't even know that necessarily. But for them to say that, again, that they're enjoying the benefits and are appreciative of that is makes my day every day. Never get tired of that.
No, I agree. And what about your least favorite thing, other than, for me, it's the wait time, but they always complain about 2 hours to 4 hours. And like, we told you on the phone, we get emergencies, but that's always the biggest complaint. But I always tell them that we appreciate their time, and their time is as crucial as my time. And I'm sorry, but what is your least favorite thing coming from a patient?
I can say from the get-go that the question that ultimately pops up, regardless of how many times you say they're going to need ongoing treatments, they'll say, so when can I stop the treatment? Or do I need to continue to get injections? It's like, yes, we've been through this before. We can't really stop for the most part. I have to say, a few good things came out of COVID, and we talked about wait times. We got our wait times down because I think COVID taught me and my associates in my practice, just when we thought we were efficient, we got a little more efficient to keep those wait times as low as possible. So I think we're getting better in that too.
That's good. I need to come visit you, Carl, and I just like I learn everything else from you. I'll make sure I learn how to cut. I think I talk too much. Maybe that's my
I'm
issue.
sure you're efficient.
But I'll see. But yeah, we're working on it. During the pandemic, our times were low too. But then now there's so many trials and so many patients that need our help. But that's a good comment about injection. They always forget, even though you tell them we don't have a cure, we just have a treatment. I think they just need to be reminded that this is a lifelong disease. And
you know what? And it also points back to what I mentioned, that they don't enjoy this. No one ever said, I'm looking forward to my injection. And so just the fact that they say that, and they know, they know you said, oh, you got to keep injecting. Maybe they're just hopeful that someday it will come to a halt. And maybe that someday is with gene therapy. Who knows?
No, I agree. I think that that's true, that they know the answer, but they're just hoping that the answer may be different for them. Okay, so next question is, what if you are not an ophthalmologist? What profession would you have liked to attempt? And what profession would you have been horrible at?
Well, if you're talking medicine, um, I did like a variety of different surgical subspecialties, ENT, orthopedics, cardiac surgery, and so forth. So again, it's more the procedurally oriented, come, let's fix the problem type of medical field, because what I would be horrible at would be the exact opposite, like psychiatry. So things I just can't fix, or have to, you know, try to talk patients into being better. That's a hard thing to do. But if you're not talking ophthalmology, you're not talking medicine, gee, I don't know. I really enjoy medicine. I'm so glad I'm in medicine, and in particular, retina. Retina's been wonderful, of course. But if it's not retina, I mean, if it's not medicine, I still, it goes back to my background in the undergraduate years of pharmaceutical sciences. I probably would have done something in the pharmaceutical industry, because that's where I really find it's the challenges of business with helping people is just very rewarding.
No, I think that's very interesting, Carl. And the next question I ask everybody, what is your favorite retina related word?
Oh, there's a curveball question. Let me think about that one. Favorite retina related word. Well, it's kind of favorite, but it also bugs me too. Ellipsoid zone.
Nice.
It doesn't bug me. It just bugs me that I'm not sure we truly understand what's going on with the ellipsoid zone. Sometimes people imply that the loss of the ellipsoid zone is a marker of a permanent vision problem, but it may not be. We all have seen ellipsoid zone recoveries from a variety of different scenarios. But ellipsoid, I love it. I love the word. I love the sound of the word.
I like it. Ellipsoid zone for Carl Regillo. Okay, and last question, Carl. You have trained hundreds of residents and fellows. You have made a great impact in retina. You have written books. You have given phenomenal lectures. You have published hundreds of papers, and you have such a successful career, Carl. And I tell you, you have mentored so many people. And there's not a single person that says, Carl Regillo wasn't nice. Everybody thinks you are phenomenal, you are nice, and you are so successful. And you're such a great surgeon. One thing I hear from fellows that train with you, that you are such a fantastic surgeon. So tell me, when you retire following this successful career, and I know it's another 20 years because it's still so young, what do you hope that patients and colleagues say about you?
Well, you use the word already. And for patients, I certainly hope they say that I've made a favorable impact on their quality of life. I mean, that's why we became doctors. Our field has evolved to the point where it's easier and easier to do that. But that it's a wonderful thing, of course, to preserve or improve someone's vision and have them function well in life. And so I certainly hope there's lots of my patients that say I made that sort of impact in their life. And for colleagues, I'll use the same word, but in here, it's more about an impact on the field that I hope I played a significant role in moving the field forward and getting us better treatments for our patients. And so I certainly hope that's how people describe my career.
Thanks, Carl. And as you know, both of those are already true. So thank you for coming to our podcast, Carl Regillo from Wills Eye Hospital. Thank you, Carl, for being here. And I also want to thank the listeners to listening to Inside the Doctor Studio Retina podcast. Thanks, Carl.
Thank you so much, Ashad. I really enjoyed it. Pleasure.